what we are going through in theory lecture? Portal veins. Okay. All right. Okay. So you have an understanding of the GI system as we are going through the lectures. Now we are going to learn about some of the organs. We call them as viscerals. In abdomen, we are going to encounter several viscerals. We are going to learn them individually, and we are going to learn them in the dissections as well. So we have to identify these viscerals for the practical purpose, as well as for the dissections, and as well as for the theoretical understanding. Now this particular organ that we are going to learn today is the liver, the largest of all organs that we have, especially in the abdomen, and largest and heaviest as well. It has a weight of roughly like 1.5 kilo, variable of course from individual to individual, male, female, depending on the sex, age, and it's having a huge size and highly vascular. Like it has 2 sets of blood flowing through it, like normal systemic circulation that is flowing through, as well as a special set of the veins enters to it, as we are saying, the portal veins, which takes up all the nutrients, brings it to the liver, which is a storehouse, keeps it there and gets out. So it has a dual blood supply in a way. So it's highly vascular. If you have any trauma injury to it, it bleeds really heavy, and the organ which is internal to it, the bleeding will be internal. So if you have an injury in the upper part of the abdomen, central part of the abdomen, if it is hitting and ripping this liver, it's going to bleed heavy and really heavy. You need to act urgently if you have to. Now for anatomical purpose, we have to understand the parts of this particular element or this particular viscera, how we are going to have this particular viscera in terms of like different parts of it, what are the the areas of clinical importance that we have to know, and moreover we have to learn that based on how we are going to see in practical and as well as in theoretical correlations. Now this particular organ which is placed in the upper side of the abdomen or upper abdomen, and we know the quadrants of the abdomen. So right upper quadrant and the epigastric region, it is largely placed, and the part which is encroaching to the left side as well. So left hypochondrium, epigastric and right hypochondrium largely placed on it, and it is a kind of a shape of a wedge which do not have a proper shape, which is having a fitting shape, and the right side of the organ, it is like a larger, bulkier than the left side. So large side of this particular right side, which is larger, heavier as you compare to the left side, which is related to the spleen on the left side. Now this particular organ, as we are seeing here, whenever you are going to talk about, we talk about this organs can be divided or described as parts of how many lobes it has, how many surfaces it has, and what are the important peritoneal relations which are related to it, and what are the blood vessels or what are the important structures that is going through, coming out through this particular liver that we are going to learn. So if you just like have this particular organ viscera, first we talk about the surfaces of this particular viscera. Now this particular organ have got 2 surfaces if you are describing it too broadly. One surface is covered by the peritoneum, we call them as peritoneal surface. And other surface which is non-peritoneal but related to the viscera or organs, we call them as visceral surface. So 2 surface broadly we can say that in simple words. So one is peritoneal surface which is non-visceral, which is related to the parietes, that means body walls, bones, muscles, etc., etc. Other thing which is related to the organs, we call them as visceral surface, which makes some impressions under to it, we call them as visceral surface of the liver, parietal surface of the liver. So this surface which is visible, shiny out here, anterior and superior, which you see that in this region where I am just like putting my hands over here, these are the parietal surface, which is related to the parietes, body wall. Upper part which is related to a muscular structure, we call them as diaphragm, the diaphragm which is present in here, which is also related to the parietal surface, and on this side posterior and posterior inferior, back side, which is related to the organs or viscera, we call them as visceral surface. Visceral surface is not by some of these particular organs and viscera making an impression, they have some kind of impressions to the sides which is related to it. So posterior or posterior inferior, which is related to the organs, we call them visceral surface, anterior anterior superior, which is related to this particular parietal surface. Now other than this liver can have some of the surfaces, like this is superior surface which is related to it, this is anterior surface, this is right side lateral surface, this is posterior surface, and which is blending with this inferior part, posterior inferior surface. Left surface, which is basically a line over here which is present. So to describe this particular liver, we just like stick to these particular surfaces, which is two out here, visceral and parietal. And if these examiners or the professors wants to know about, do you know anything more about these two surfaces, then you just like go on telling about the surface, anterior surface, superior surface, right lateral, which is can be fitted with, and posterior or posterior inferior surface, which is visceral surface itself. Now coming to these particular viscerals, coming to these particular surfaces, from there we are going to talk about some borders. So one border that you see that, which is extending from here, rolling down to this point and arching over this particular left side. So right side, right angle or right lateral side to this lower part bottom, and then grooving in and then moving to the left side, we call them as inferior border of the liver. So this particular border is really prominent. So this inferior border is continuous with the right lateral border, which is going up. So this inferior border, which is present to this particular liver at the undergraduate level or this any given level, the inferior border is the only border which can be examined, failed during clinical examination. So that's a significant border that we have to know. So this border we call them as inferior border, which is marking this particular lower limit of this organ, which is can be continued up as right lateral border. This is the right side of the liver, left side of the liver. So this particular liver have got two lobes to understand anatomically out here. Is this, we call them as this lobe, we call them as right lobe, and this side we call them as left lobe. These lobes are unequally divided, they are not same. So this right lobe is larger than the left lobe and split by this particular attachment of this particular fold of this peritoneum, we call them as falciform ligament. So this ligament which I am holding, we call them as falciform ligament. So this falciform ligament runs into the substance of the liver, splits these lobes of the liver anatomically into two unequal lobes, right larger lobe and left to it left lobe of the liver, which is smaller. So large right side liver, we have the lobes which is bigger. Now if you just like go on the posterior side, the right side also have got two small lobes on the posterior side or visceral side. So this one which is separated out here, we call them as caudate lobe, and this one we call them as quadrant lobe. So this sublobes is also there. So if you just like going to talk about the lobes of the liver, right lobe, left lobe, caudate lobe and quadrant lobe, this is another way you can describe. Or else you can start with anatomically can be divided into right bigger lobe, smaller left lobe, and the right lobe consists of these two sublobes, caudate lobe and quadrant lobe. Caudate with the C, quadrant with Q, right? Caudate is above, quadrant is bottom, lower side. So two lobes and two sublobes, or you can say that right lobe, left lobe, caudate lobe, quadrant lobe, that's it. Surgically, it can be divided into further subdivisions based on this presence of this like biliary system, based on these vascular channels that is present on it. It can be divided into 8 to 10 lobes or sublobes based on like Roman letters 1 to 10 or 1 to 8 like that, right. So I am not going to talk about those things anatomically, we are speaking out here. So we restrict the anatomical segment first. So when you ensure the anatomical domain, then we can talk about the other things. So talking about this particular surfaces, two surfaces to talk with, visceral and parietal. Visceral means related to the organs, parietal means body walls. Parietal ones covered largely by this particular diaphragm, which is covering on this side and which is related to the ribs, intercostal space on the right side, left side as well. In the middle we have this particular like falciform ligament splitting this particular lobe into two unequal lobes, right bigger lobe, left smaller lobe. Right lobe have got sublobes, caudate and quadrant, or else four lobes can be talked about, right, left, caudate and quadrant anatomically can be divided into it. Now talking about this particular borders, one prominent border that is present all throughout is inferior border, which is easily identifiable. Inferior border is extending from the right to left, and right border, right side inferior border can be merged or can be linked up with the right marginal border, right border of this particular liver, which is continuous below in the inferior lobe, inferior border. Inferior border is the only border of the liver which can be felt or clinically examined. From this inferior border, if this particular liver keeps on enlarging or enlargement of the liver, it can be moving up or it can be going down. So, if this particular liver is enlarging, the inferior border becomes palpable below. Normally, the inferior border is just palpable below this particular ribs margin. So, costal margin below these ribs, we can just feel this inferior border, which is normal thing. So, if you can feel the liver below this particular costal margins, 3 fingers, 4 fingers like that, that means liver is enlarged. We call them as hepatomegaly. The upper enlargement cannot be felt because it is moving up, it is pushing on the diaphragm. We cannot feel through the rib cages. So, inferior border of the liver is the only one which can be felt, examined and can be assessed if the liver is enlarged or not. If the enlargement of the liver is there, we measure it by centimeters or by fingers, 1 finger, 2 finger down the costal margins. Clear? Now, coming from this particular lobes, surfaces and this particular borders, we are moving to this particular surface out here, which is related to the peritoneal or non-peritoneal. So, liver is largely covered with the peritoneum, which is a double layer membrane that is present around this all the viscera that we have. Now, a part of this liver which is non-peritoneal. So, largely this liver is covered by the peritoneum. Some areas is not covered by the peritoneum. We call them as peritoneal area of the liver and non-peritoneal area of the liver. So, the non-peritoneal layers or non-peritoneal areas of the liver, we call them as the bare areas, B-A-R-E, bare, which is not covered with peritoneum. So, liver surfaces as we have seen, parietal and visceral layers which is present can be like described at some parts of the liver surfaces is covered by a peritoneal. So, we call them as peritoneal surface and some is not. So, liver is largely covered by the peritoneum. So, some of the areas which is not covered by peritoneum, we call them as non-peritoneal surface of the liver or areas of the liver. That non-peritoneal surface of the liver, we call them grossly or in a general broad heading as the bare areas. So, the bare areas are of different types or different sub areas of their bares. So, largest of the bare area, we call them as the bare area. Just like we announced that like the diaphragm. So, the largest of the diaphragm that we have, the diaphragm. So, similar to that, the largest area of the peritoneum, area of the liver which is non-peritoneal, we call them as the bare area of liver. So, where this the bare area of liver is present? On the right lobe of the liver. Which part of the right lobe of the liver? In the superior part and the posterior part or posterior superior area of here. So, this area, superior surface and as well as posterior surface, as you can see, looks like rough compared to this area which is look shiny. So, this shininess is because of the attachment of the peritoneal. Peritoneum is attached on it. So, the visceral layer of the peritoneum is attached on it. That is why this is looking shiny. And this area, as you can see, that looks like rough, visible and can be felt as well. So, this area we call them as bare area of the liver, which is largest of all. We call them as the bare area of the liver. So, this area have a boundary which is related to it. So, we call them as the bare area of the liver, which is non-peritoneal, not related to the peritoneum. Other than this, we have several other peritoneal areas which is non-peritoneal. Like there are some grooves on the visceral surface or posterior inferior surface. You see that these particular groups which is separating between the caudate lobe and quadrant lobes. So, we call them as this particular area as groove for ligamentum venosum. This upper groove which is present between the left lobe and this caudate lobe. We call them as groove for ligament of venosum. And the bottom one we call them as groove for ligament of teres hepatis. So, groove for ligament of teres hepatis which is in this one. So, it is kind of like a V-shaped groove which is present in here. This is upper limb of the V, lower limb of the V. This upper limb we call them as groove of ligament of venosum. This one we call them as ligament of teres hepatis. So, these grooves or floor of these grooves are non-peritoneal. So, these grooves have walls, anterior wall, posterior wall and a floor. Floor means going in the depth of it. So, this floor of it is occupied by something, that is why the peritoneum is not reaching inside. So, the floor of these particular grooves are non-peritoneal. Groove for these venosum and teres hepatis, the floor of it is non-peritoneal. If you move from this side, this caudate lobe, this area, we have a big vessel which is present in here. So, we call them as this area which is present in here, which has a large vein over here, we call them as inferior vena cava. So, this inferior vena cava is lodged in here. See sir? So, this is the cavity of the inferior vena cava where through my fingers are going. So, this particular inferior vena cava is lodged within the substance of the liver. Now, as it is, this inferior vena cava is lodged in here, peritoneum cannot go in. So, where this particular inferior vena cava is lodged, that space we call them as groove for inferior vena cava. So, if you strip this particular inferior vena cava off the liver, you find the floor of it. So, the floor or this groove of this inferior vena cava is also not covered with peritoneum. So, we call them as groove for inferior vena cava is also non-peritoneal. So, where this groove of inferior vena cava is that? Between this right lobe of the liver, this side is the right lobe of the liver and this is the caudate lobe. So, in between that we have this groove for inferior vena cava. Now, where this inferior vena cava ends in here, we have a space. This particular space we call them as the entry door for the liver, this one. We call this entry door of this liver as porta hepatis. So, this porta hepatis through which some structures of the liver gets in and come out. So, this porta hepatis is also not covered with the peritoneum. This is also non-peritoneal area or bare area of liver. Now, from here we go down to this point. So, this particular area where you see that from the right lobe and this quadrant lobe, we have a sac-like structure present. This sac-like structure we call them as the gallbladder. See, this is a gallbladder which is hanging from this region. So, this gallbladder is placed in here. So, this gallbladder under to it is also non-peritoneal, not covered by the peritoneum. So, this fossa of the gallbladder or the floor of the gallbladder is not covered with the peritoneum. So, we can call them as non-peritoneal. There are other areas also which is present, minor areas which is also non-peritoneal. So, these are the non-peritoneal areas of the liver. So, write it down, mark the or identify the non-peritoneal areas of the liver and mentioning the bare area of the liver. The bare area of the liver is a short note, exam short note, 2 mark short note with a schematic diagram that you have to prepare for examination. So, mark or write down the non-peritoneal areas of the liver which is known as in bracket or in semicolon we call them as bare areas of the liver. Mark the largest bare area or the bare area of the liver, its situation and its boundary and the organ or viscerals related to it. So, you prepare this for a 2 mark exam short note. Boundary of it and content or visceral relations related to the bare area of the liver. So, second question you write it, describe the surfaces of the liver, 2 mark. Now, describe the lobes of the liver, 1 mark. Describe the borders of the liver. Describe the porta hepatis. What do you mean by porta hepatis? What structure gets in and gets out of the porta hepatis and what structure do not pass through porta hepatis, and why the porta hepatis, or explain why porta hepatis can be called as not a true gateway of liver. What is porta hepatis? Mark the area or the structures that is going through or coming out of porta hepatis. What structure do not pass through porta hepatis and why, or explain why porta hepatis can be called as not a true gateway of liver. Alright. So, after that we are going to talk about the last features which is related to these particular structures that we are going to talk here is the visceral surface that we are going to talk. Now, this is the visceral surface which is related to the posterior side and inferior side. So, we call them as posterior inferior surface of the liver which is related to the organs and the viscera. Now, how they are placed? They are making some impressions on the levers. So, right or left side you have to have it. So, this particular lever, as you are seeing here, we have held it in normal anatomical position. So, this is the left lobe of the lever. So, next to this point where you have this particular ligament of a groove for venosum, on here we have a groove for esophagus. So, vertically esophagus comes here and ends in here. So, where the esophagus ends in? Esophagus ends into stomach. Thank you. So, esophagus ends in stomach. So, here we have the groove or marking for the esophagus, which is ending into this particular impression which is living here. We have the stomach. If you see the stomach here, we have this fundus of the stomach and the body of the stomach, which is related or making an impression from here. So, this esophagus to the stomach which is related to it, making an impression to the left lobe or left posterior inferior surface. Esophagus, next to that we have a stomach. Now, likewise we flip to the right side, right lobe of the liver. Here we have an impression for. So, we have a solid organ lying on the posterior side of the abdominal wall. We have the kidney. So, the right side kidney which is making an impression out here. So, right kidney which is related to this particular point, which is inching towards this area. This area we call them as the bare area of the liver. So, inching towards here, we have on top of the kidney, we have a small gland which is existing on it. We call them as suprarenal gland or adrenal gland. So, adrenal gland is basically making a visceral impression on the bare area of the liver. Here, so this area which is making a mark over here, which is related to the right side kidney or anterior side or anterior surface of the kidney. Here we have the groove for the gallbladder. So, this is the gallbladder that you are seeing here. So, gallbladder which looks like a pouch or kind of like a dilated sac. So, this gallbladder where I am holding here is the middle part of it, we call them as body. We call them as body. The lower part which is hanging down here, which is hanging or related to the inferior border of the liver, we call them as fundus. Fundus of gallbladder, body of the gallbladder. Fundus of the gallbladder, then we have the body of the gallbladder, then we move to this part, we call them as neck of the gallbladder. Then the neck drains to a duct, we call them as cystic duct. So, you know the parts of the gallbladder, write it down, mention the parts of the gallbladder or different parts of the gallbladder with a small schematic diagram. Or what are the parts of the gallbladder? Describe it with a schematic picture. একটা ছবি আঁকে দেখাবে different with a label diagram. Now, see that. So, we have here the stomach, we have the esophagus, we have the kidney, suprarenal gland which is related to it. Now, we have on the other side of this particular gallbladder which is related to the intestine or coils of small intestine. So, here you have the duodenum after the stomach which goes down. We have the duodenum and the jejunum or small intestines which are related to this parts over here, and as well as we have some parts of the colon, we call them as transverse colon. So, we have a colon which is changing directions. The part of the colon starts from the point we call them as cecum and appendix, which is related to the right iliac fossa out here. So, after that this point which is cecum lies in the right iliac fossa, it moves up, we call them as ascending colon. Ascending colon reaching to this undersurface of the liver makes a bend, we call them as flexure or bend, which is related to the stomach, related to the liver, we call them as hepatic flexure. So, it is making a bend at the right angle, that means going up and then bending on the right angle. The bend is related to this point where this particular organ which is related out here next to this particular gallbladder fossa right side, under this particular impression of this region we have the kidney, lower part bottom, next to that we have this particular coils of or bending point of the transverse colon, we call them as hepatic flexure. So, that hepatic flexure or the bend which is related to it, then it runs transversely under to it, we call them as transverse colon. Transverse colon makes no impression in here. Then the transverse colon goes on the extreme left side. Then related to the extreme left side, we have an organ, we call them a spleen. It hits the spleen and makes a bend again. We call them a splenic flexure or left side flexure. So then after hitting the spleen, it goes down again. You see that it's like snake kind of thing which is moving down, the old snake, like the video game we used to play, going down, moving up. So it's kind of like that thing, going up, hitting, then moving, and then hitting, again going back, like that. So ascending colon, transverse, descending colon. In between them, they have two bends. We call them as flexures. Liver flexure, splenic flexure. So hepatic, splenic, or right flexure, left flexure. Clear? In between, transverse colon. Transverse colon is hanging below. It is not related to this. Only this flexure which is related to this particular liver, which is related to this surface under this particular or near this particular region, we have a flexure. Clear? So this particular coils of small intestine, jejunum and duodenum on this side, and we have the large intestine bend, we call them as hepatic flexure, which is related to the under surface of the right kidney. So these are the major impressions of the organ that is related to it. So again, left side, right side. Left side we have esophagus ending into curving into duodenum. Then we have this gallbladder. Then it is its end of story. Left side we have this kidney. Right side, top of the kidney, suprarenal, related to the Dabbe area. Then we have this thing coming up, flexure, getting in here, bending in here. Coils of the jejunum, which is related to the side, and making an impression roughly into this particular points. Now this particular impressions, why this particular thing is important? Because whenever you are going to operate in this particular region, you have to encounter these particular organs. So you have to be careful whenever you are going to dealing with it. Say for example, you are going to work on this particular gallbladder. So you have to know that what are the nearby neighbor structure that is related to it, or else you will be hitting them or damaging them, which we do not want. Okay. Now last not the least, coming to this particular point, we have this particular point which is related to a forceps. Ask for a forceps. Related to this particular point, we call them as porta hepatis. Porta hepatis means structures gets in, comes out of the liver. Now we have three structures that is related to this particular region. One is hepatic artery, one is portal vein, and other is the bile duct, which is getting out or related to this particular. Along with this, we have the lymph nodes, we have the nerves, which is going to supply these particular regions. So we have the arteries, we call them as hepatic arteries. It has two branches, right side hepatic artery, left side hepatic arteries getting in. Likewise, this portal vein, which is have single, and this particular portal vein which is getting in, which is present to it. The portal vein, easy to identify it as it is having a wide caliber lumen. So if you look at this particular structures which is present to it, you will see there is a wide lumen structures, flat wide lumen, bigger lumen, which is a portal vein, easy to identify whenever you are sitting in. And then you have to identify this particular other structure which is having a thicker lumen, which is a hepatic artery. And then we are left with one thing which is related to this particular bile system. We call them as the bile duct or hepatic bile duct, which is coming in here. The bile duct ends into a duct, we call them as cystic duct. So cystic duct is related to the gallbladder. This is a cystic duct which is related to this gallbladder. And then we have this particular hepatic bile duct, which is this one, and other two which will be easy to identify based on the lumen of the caliber. The wider lumen will be the vein. What vein is related to here is a portal vein. So whenever you are going to see them clinically, or whenever you are going to see this organ in here as well, so you have to identify them based on the lumen of the caliber of these particular structures or lumens. Three of them are there. You have to judge with how they are going to it. The wide lumen, easy to identify, it will be vein. One vein is getting in, portal vein. Other two which is narrow. One is bile duct, other is hepatic arteries. Hepatic artery usually two which is going in. Bile, easy to identify if it is fresh because they have a bile stain, greenish or yellow greenish stains will be there. As because these are long time kept viscera, you will lose this particular dyes. So whenever you are going to see, you have to track it little bit. where it is going in. So, if it is coming from this particular like portal vein or going to this particular like gallbladder, we have to correlate it accordingly. Now, what structure is not getting into this particular portal vein is this one, which is a groove of inferior vena cava. You see this? This is the inferior vena cava, where I have passed this particular forceps through it. So, this particular inferior vena cava, if you look at the floor of it, you will find that it is pierced by some of the veins. We call them as hepatic veins. So, this hepatic veins opens directly into the inferior vena cava. So, this particular hepatic veins is visible through this particular the cavity or lumen of this inferior vena cava. So, this inferior vena cava is this one which you have to identify first. So, whenever you are going to have this organ, you have to have it in a normal anatomical position. So, how we are going to place this in normal anatomical position? This is the right side, this is the left side. Now, groove for inferior vena cava should be kept in vertical position, because inferior vena cava going straight, vertical, just like rocket is moving up. So, this groove for inferior vena cava has to be placed in vertical. Is it vertical? So, how to make it vertical? I have to tilt it towards me or towards you? Towards you, towards me. So, it is dropped, that means it is vertical now. So, you have to make this lumen vertical. So, you should have a forceps during examination, which is the most precious thing that you have, which you do not have, right? You never have any forceps, never ever, because you only want to have a stethoscope, nothing else. So, keeping forceps is useful because it helps you to identify this, place it, then vertical. So, this is the normal anatomical positions of the liver. So, coming back to the liver, surface of the liver, parietal, visceral. Subsurface, if you want to mention, right lateral, anterior, superior, posterior side, which is related to here is visceral, also can be posterior inferior or visceral surface. Borders, inferior border which is largely visible, stop it at that point. If they want to know more, right lateral is prominent, which is merging with left side also, but not very prominent one. Superior border, you can say that is a vague. So, this border which you are saying superior, which do not have any proper demarcations, you cannot trace it properly, but it is visible, can say that superior border, inferior border, right lateral, left side, not very prominent borders are there. Inferior border which is running across. Lobes, two lobes anatomically, right and lobe, split by attachment of pulse. Then quadrant and quadrant is a part of right lobe or left lobe, right lobe, okay, right lobe. So, how many lobes together? Right, left, quadrant, anatomically. Surgically, many lobes. Let me go to the surgery class, we will learn. Okay. Then grooves between and inferior vena cava mentioned, and this one groove for or fossa for gallbladder. It is not a groove, basically it is a space that we call them as fossa. Coming to these organs which is related to it, gallbladder কি পার্ট আছে বেশ how to have this organ in normal anatomical position, it should be vertical, should be looking at the floor of it. এখান থেকে দেখা গেলে ফ্লোর দেখা গেলেও বোঝা যায়, অনেক সময় পরীক্ষার সময় এটা তো থাকবে না তোমাদের, তো এটা ফ্লোরটা দেখতে পাবে যখন তখন বুঝবে ভার্টিক্যাল হয়েছে, থ্রু ইট ইউ ক্যান সি দ্য ফ্লোর, if you can then it is vertical. Okay.
this inferior vena cava is cut here. So you can see the floor of the inferior vena cava, which is pierced by the hepatic veins. So these hepatic veins are opening in here in this inferior vena cava, which is visible in there as well. This area we call them as porta hepatis. Porta hepatis have got three structures: portal vein. Now in here we have the stains, which is visible. This is a thin walled structure. Lumen, vein. This one have got stains, bile duct. This one, arteries. Easy to identify by this texture and look of it. So first you have a look on this particular portal structure, then you can identify this. Now this particular groove we have got groove for ligamentum venosum, ligamentum teres hepatis. So this is the ligament of teres hepatis, which is known as a round ligament of the liver. This one, it looks like round, known as round ligament of the liver. Round ligament of the liver falls on this particular ligament or marches on this falciform ligament. So it is dropping on this particular remnant. These are all embryological remnant. Ligamentum venosum is for the ductus venosus, which was a infantile channels for the passage of the blood, and ligamentum teres hepatis is obliterated umbilical vein on the left side. Left umbilical vein obliterated becomes this ligament like structures, right, which becomes a peritoneal structures or peritoneal like structure, but it is a false ligament which is related to it. So see this particular organ viscera, first you identify it, different parts of it, lobes and the visceral impressions that I have mentioned, and then come to this particular viscera, identify it, and don't forget to identify that have this particular in normal anatomical position. কোথা থেকে আসছে দেখ, হ্যাঁ কোথা থেকে, হ্যাঁ সিস্টিক ডাক্ট, বেশ এবারে এটা সিস্টিক ডাক্ট হয়ে গেল, কোথা থেকে আসছে, গলব্লাডার থেকে, বুঝতে পেরেছিস, বেশ এবারে দেখ 1 2 3, ঠিক আছে, এই দেখ এটা পোর্টাল ভেন বড় সাইজ, ঠিক আছে, এটা হেপাটিক আর্টারি, এটা বুঝতে পেরেছিস, কি করে আইডেন্টিফাই করবি, দেখ দেখে নিয়ে সবাইকে দেখা, লজিক গুলো বলবি, খালি মুখস্থ বললে হবে না, ধর নিজে হাতে ধর, ওই হাতে ধর, হ্যাঁ আমাকে বল আগে, হ্যাঁ দুজন দুজন করে গিয়ে সবাইকে দেখিয়ে দে, সবাই সবার কাছে যা, গিয়ে দেখিয়ে দে, বস দুজন দুজন করে বস, সবাই নয় দুজন দুজন, 2 at a time।